Welcome to the Microsoft Cloud Digital Series in Healthcare. My name is Kevin Chia. I'm the Canadian Marketing Healthcare Lead. And man, do we have a really good program in store for everyone today. But before we begin today's programming, I got a couple of housekeeping items for everybody. First, on the left side of the screen, you're going to see our live Q&A chat. Any of our panelists will be available to answer any questions you have on the content using the text Q&A. So if you have any questions, I highly encourage you to ask them as they'll be available for chat. If you're tuning in on demand, well, you can always reach out to us using some of the resources below. Second, everybody is going to receive a copy of today's webinar within 24 hours. If you didn't get it, check your junk mail. Third, on the right side of the screen, you're going to see our survey. Love the content, hate the content, wish we would cover another topic in Canadian healthcare technology? Let us know. We really value some of that feedback. Last but not least, I'm really proud to say this, but today's webinar has been closed captioned for accessibility. All you have to do is turn on the accessibility captions below. That's all I had for housekeeping items. I'm going to go ahead and introduce our host for today. Sit back, relax, and we hope you enjoy the show.
Good afternoon, and welcome to another episode of the Microsoft Cloud Digital Series for Healthcare. I'm your host, Peter Jones, Healthcare Industry Lead for Microsoft Canada. On today's episode, we will be discussing new innovations in mental health access for Canadians with a central intake approach, with some amazing speakers from Novari Health, CAMH, and Halton Healthcare. But before we begin, I wanted to start off by saying thank you. Thank you to all of our healthcare providers and first responders across the country who have put themselves in the front lines to protect health, safety, and prosperity for all Canadians. Our Microsoft team has been privileged to really play a small role to partner with providers and organizations to deliver healthcare solutions to frontline healthcare workers in Canada. As many of you know, the landscape for healthcare has changed dramatically over the last 12 months to 14 months with COVID. And we're starting to see a real shift and stress is put on a lot of the healthcare workers in Canada. We're seeing a lot of elective surgery being pushed off. We're seeing a lot of healthcare workers really struggle given the number of hours they're working to really provide those critical services to healthcare patients, as well as really treating with their own mental health and wellness as they go to work every day. As many of you know, productivity is really impacted by mental health. It's really the number one cause for disability in the world when it comes to the workplace. We're seeing a lot of productivity loss due to absenteeism in the workplace, not just for healthcare workers, but across a number of organizations serving the public, as well as just the onset of working from home, working remotely. That brings a whole set of challenges for individuals to determine, how do I find that work-life balance? We're seeing some interesting stats as we survey the market on a number of individuals who really try to stay connected to the workplace, even though they're working remotely. Some of the stats we've been able to understand is really that 70% of workers really have a hard time truly unplugging from their day's work. Another thing is really the disruptor around, it's the number one challenge. People are always thinking about work when they're at home and trying to find that work-life balance. An interesting fact I heard was 87% of people read emails after hours, and 30% of people check their inboxes before getting out of bed in the morning. So how do we really help individuals find that work-life balance? Microsoft has really tried to put a step forward in launching some new services and capabilities for a lot of our employees to really find that emotional well-being and work-life balance for our employees. We've actually launched something called Viva Insights that allows our teams to really be able to manage and monitor how our employees are doing across the board. So with that said, I also wanted to talk about what Microsoft is doing around launching a service called Microsoft Cloud for Healthcare. And we really launched this to help partners like Novari Health here today, help them build a lot of those solutions for our healthcare organizations, as well as many of our customers around the world. So let's get started today with introducing our panel, as well as get into the topic of what we're here to talk about is how to do that mental health and wellness with this central intake model. Let's go ahead and welcome our panelists. With us today is Stephanie Carter, Clinical Director at CAMH. Welcome, Stephanie. Maybe you could tell us a little bit about yourself and your role at CAMH.
Sure. Thank you, Peter. So I'm a clinical director at CAMH. I've been at CAMH for the past 10 years, and my portfolio involves oversight for the operations of our ambulatory services at CAMH, which includes our centralized referral service, Access CAMH.
Okay, thank you, Stephanie. And with us as well is Nella Sharan, Manager Central Intake from Halton Healthcare. Welcome, Nella. Can you tell us a little bit about yourself and your role at Halton Healthcare?
My name is Nala Sriharan. I'm the manager for the Mississauga Halton Central Intake Program, OneLink, and Self-Management Program at Halton Healthcare. So as part of my portfolio, I look at the regional coordinated access for multiple pathways, as well as the regional self-management program.
Thank you, Nella, and welcome. And finally, John Sinclair, who's president of Novari Health. I've worked with John for many years. And I just wanted to say welcome. And John, maybe tell us a little bit about yourself and your role at Novari Health.
Hi, Peter. Good to see you again. So I lead Novari Health, a team of about 80 wonderful people who would normally be in our bustling office here in downtown Kingston, Ontario. If it weren't for the pandemic, I'm the only person here, so 80 empty desks today. And I've been with Novari Health now coming up on, well, I think actually just exceeding 12 years.
Great, welcome, thank you. Okay, so what I wanted to do is turn it over to you, John, to take us through a little bit about Novari Health and the solution you're providing around mental health and the central intake approach that you've taken. So I'll turn it over to you. Thank you, John.
Yeah, thank you, Peter. Thank you very much. So, you know, we're in the middle right now of the third wave. I have to admit it's much worse than I had anticipated. It's certainly impacting our family a lot with my significant other being an ICU nurse at Kingston Health Science Center. So the healthcare system is really overwhelmed here across the system. Mental health, surgical services, you really name it. There's a number of ways we can tackle the problem of access to care. And even before the pandemic, Canada really struggled, Peter, with regard to access to care. We're one of the worst performing countries. Now, of course, with the outcome of the pandemic is still underway. It's worsened, and it's worsened right across the healthcare system. So there are traditional ways that patients queue for healthcare services, how we get in line, and we've all experienced this. There's a traditional way where you go to sometimes your family physician. He or she makes a referral for some type of healthcare service. They often don't know where the best places are to send you, and I think we're going to hear that a little bit later. When we talk about mental health and addiction services. And when they do pick a provider to send you to as a patient, they most often don't know all of the available providers, nor do they know the wait time for each provider. And so, that's the traditional model. We all get into these individual queues. There's very little transparency for the person making the referral, the provider making the referral. And there's certainly no transparency for us as patients as to, which queue are we in? What's the wait time in this queue versus a wait time in another queue? Where might we have been sent to? And what's the triage process in this whole thing? So maybe I should be seen, frankly, Peter, before you, based on my urgency and my comorbidities, or maybe it's the other way around. And so are we really getting the right patient to the right provider at the right time? And I would add to that, because that's a common expression these days. But I would add to that with the right data. You hate to get to that appointment and then the provider you're sitting across from say to you, well, Peter, where is your lab result, or where is this consult report, and you don't have it, and it wasn't sent along with your referral. So these are the bottlenecks in this system. What the pandemic, I think, has brought to the forefront, and we've seen this in the literature, including the Canadian Medical Association Journal in the last, since the beginning of the pandemic. There's an appetite now to move to a different model of care, and that's a central intake model. Central intake is just a way of load balancing demand, patients, if you will, are equally across all available resources, so that it doesn't matter which line you get in, you're always in the right line. It's the right line for you. So that's it's a shift in thinking, frankly, as to how we can improve access to care for patients. There's been some opposition in the past. This requires significant change management. It's a different way of thinking, but its time has come, and we're seeing it. So many voices across the country and internationally now, where providers themselves are realizing that this is a better way to be seeing patients and to be triaging patients. So that's really what central intake is. It's a single point of entry, and we can single point of entry, or a common way of having patients access a service. Central intake can be deployed at different levels, and what it looks like for one healthcare organization or one region can look different elsewhere in the country. How you set up a central intake model for medical imaging in British Columbia might look completely different than how you would do it in Saskatchewan or in Nova Scotia. And then again, mental health services would look different from region to region or organization to organization. What we found is that, and I think we'll hear this today, is that central intake models work. They're very effective. It's equitable. It's transparent, but without an enabling technology, an underlying technology, that air traffic control sort of technology to make it all happen, it's really difficult. You can deploy central intake and make it look different everywhere. So it's not very prescriptive in how you do it. The model is wide open. But at its root, I think you can think of it this way. You can deploy central intake at a regional or a large area, think a health region, a former LHIN region in Ontario, perhaps, or a health authority outside of Ontario, or even at a provincial level. You can also deploy central intake. That same model works at individual enterprise level or hospital level, and we'll see that with CAMH, but Novari's been able to work with regions, multiple regions around the country, not only for mental health and addictions, which is what we're talking about today, but think of cataract surgery, think of orthopedic surgery, think of wound care, think of really any healthcare service, and applying this model with local rules and adding a local flavor to it. But again, it can be done at an enterprise level or a region level. And so I think that's probably a good segue to turn to Nala, who I've known now for many years. Nala, I'm going to ask you, Nala, to describe your central intake program. And I'll tell you why, because I've traveled the country, and I know of no other central intake program that is as efficient and well structured as yours. And you had lots of barriers to setting it up, but you really broke a path. You were the person cutting through the snow that others now are following in, and you've had Australians and others come and visit you from around the world to look and learn from what you've been able to do with Halton Healthcare. And your various services. It's not just mental health and addictions. You have other services. So how have you deployed central intake, and what does your service look like?
Hi, John. Good afternoon. Thank you so much for those kind words, and thank you for having me today to share our work in Mississauga-Halton region. So our central intake journey really started over almost 10 years ago. Halton Healthcare was leading the implementation of the Ontario Diabetes Strategy Quality Improvement Initiative in Mississauga-Halton region, so the former LHIN Mississauga-Halton boundaries. One of the key deliverables was improving access and to services in diabetes for patients and primary care providers, because we have over 8 different diabetes services. It was very confusing, 20 different referral forms. So that's how central intake started. So our organization applied for funding from the LHIN, and we launched the central intake program for diabetes in 2013. And during this period, there was system planning work happening in parallel in mental health and addiction in our region as well. So all the service providers who provide addiction and mental health services funded by the Mississauga-Halton LHIN wanted to look at a central intake or single access point model. So based on the success that we had with diabetes, so this model was leveraged. So we expanded the central intake program to provide coordination access to all funded addiction and mental health services in the region. So this initiative is known as OneLink. It's funded by Mississauga Halton Lynn and led by Halton Healthcare. And central intake program then further expanded to serve as the single access point for hip, knee, and low back pain rapid access clinics in the Mississauga Halton region as well. As you know, this is a provincial initiative with each region establishing its own single access point and rapid access clinics to reduce unnecessary surgical consults and reduce wait times for hip knee surgery, as well as it's now expanding to shoulders, ankles, and foot as well. So given our existing infrastructure and coordinated access, it was decided to expand our program and technology that we had already built starting in 2014. So what we've done really is we've created a very sustainable and scalable model for coordinated access, partnered with technology within our region for multiple pathways. So through an innovative procurement process, Halton Healthcare collaborated with Novari to implement the e-referral for all clinical pathways, starting back in 2014. So it's been a very exciting and long journey. We started with one pathway, and now our program serves as a single access point for 5 different clinical pathways: diabetes, foot care in the region, mental health and addiction. We have the MSK, hip and knee, and low back rapid access clinics. We just launched the shoulder pathway. And with using e-referral and e-scheduler technology from Novari. In terms of the benefits, really it's multifold, I would say. So for a patient, the benefit is having a single access point, single contact information to be able to address their care needs, to get information, to get the referral, and getting to the right care based on clinical need and not based on known information or referral relationships. Oh, as well as, we're able to, because of the technology, we're able to gather data on wait times in real time. So being able to show the patient, okay, do you want the next available, or do you want to go a bit further or like close to home and wait a little bit longer? So these has been really powerful for the patient. For the service providers, it created an opportunity to standardize the entire referral process. This is that, going from 20 different referral forms to 1 in diabetes, standardizing the requirements for referral and access, standardizing how long a referral sits at everybody's table, being able to monitor wait times in referral processing, appointment booking. Some of the great work that we've done really in mental health and addiction is to kind of look at all our service partners, and there's an inventory of over 125 services, collaboratively really define what are the referral criteria, what are the access criteria, what's the care level or need level that needs to match in order to access this service. So almost creating a step care model within our region based on existing services. That's been some of the work that we've been doing over the past couple of years. And at a system level, to John's point, you have technology that enables you to have real-time data, and we're able to, for the first time, to see duplication of services, wait times. We're looking at capacity when one program has an overload of volume or large wait time. We're able to balance that off with another program that has a similar service and has a less wait time. So redirecting referrals and balancing the services in the region. And being able to look at where the needs are. We've been able to secure much more funding, develop new programs based on the data that we've been able to capture. So it's definitely beneficial at all different levels from what we've seen and proven and shown.
Nala, there were 2 words you said a minute ago that I scribbled down. You said, I'll quote you to you. I think you said sustainable and scalable. Well, that's what you've done. You've set up a model and you've backed it up with enabling technology to literally make it financially sustainable and then scale it out, right?
Correct.
But I remember back in the day, and I didn't know it was that long ago, actually. I'm older than I thought. I remember your hodgepodge of technologies that you were using, and we see the same thing elsewhere in Canada today when we visit them physically or virtually during the pandemic. We see a mix of paper, fax, spreadsheets, emails, maybe an Access database. It's kind of it's just not all tied together. The model might work, but it's not sustainable. It's not scalable because they don't have that underlying enabling technology. Am I getting that right?
Yes, you're absolutely right. And John, we had all of that hodgepodge of technology, as you recall, from spreadsheets to Access database and email and fax. We did until we implemented Novari, and it has been a huge change management, absolutely. But it is one thing that our partners now rave about. They actually ask, how can I get all my referrals through Novari, through central intake, even their internal organization referrals? Because it gives you the transparency in the process from the point of referral from the primary care provider to central intake and to where the patient is waiting at the receiving provider level. And at a glance, we can see the story, what happened to the referral, how long they waited, and we can now bring that data to regional tables and really drill deep, like what's the story that this is saying.
And my recollection now is that when you were in the early days of implementing your central intake model, that some of the providers who would be receiving the referrals were skeptical. They were skeptical because they thought that a central intake model would disrupt the referral patterns and delay them getting referrals. And in fact, you were going to impede timely access to care by imposing a central intake. And you had to prove them otherwise. And I think you've won them over because you're now sending them 100% complete, triaged, appropriate referrals. Is that right?
Absolutely, yes. Those were some of the queries that we did have early days that we would become a bottleneck of timely access. But what we've shown is the reverse. We process 85% of our referrals are processed within 48 hours. On top of it, we've been able to now establish regional standards where nobody holds on to referral more than 30 days from getting it from us. Versus in the past, a referral could sit at somebody's desk for 6 months and had only one attempt of a phone call to book the appointment. So that's we've really shortened that whole wait time for access across the board through quality improvement work. And we are able to show data to say, no, we are not the bottleneck. And we are to a point where any referral that we're sending, it's the most appropriate based on care level and care need versus, it's a relationship-based referral between a provider and a program, which is traditionally what happened in healthcare and still continues to happen in a lot of places. We're able to show wait times. We can show it to patients to say, okay, do you want the rapid access clinic that has a 2-day wait, or do you want to go somewhere that's close to your home, but you may need to wait 2 weeks. So I think that's really the transparency that we bring as a coordinated access point, and because of the technology, for sure.
That's great. Thank you, Nala. I mean, what we've just heard, we've heard how central intake models been deployed so successfully as a model for others, frankly. At a large scale, my recollection again is about 1.2 million people is the population of Mississauga, Halton. So you can deploy this model out at that scale or even larger, frankly. Mm-hmm. But then we can drill it down, and there are other organizations in the province. We're going to talk about CAMH in a minute, but we're also working with North York, now not in mental health, outside mental health, but with North York General. And Humber River for medical imaging requisitions. Again, a central intake model. Wound care in the north, Kingston Health Science Center for their surgical and medicine referrals. So whether it's a regional, provincial, or it's an enterprise hospital level, the same model works. Stephanie, you're very familiar with a program that's Access CAMH. I love the name. Some people might not be familiar with CAMH outside of Ontario. So maybe my first question to you is, who is CAMH? What do you do? And maybe describe the Access CAMH model.
Sure. Thanks, John. So CAMH, or the Centre for Addiction and Mental Health, is Canada's largest mental health addictions teaching hospital. We're located in Toronto, and just to give you a sense of our size, we would employ about 3,000 physicians and staff and would see about 34,000 patients a year. So our Access CAMH model was born in 2014, and the goal of it at the time was to really, and it continues to be, to provide our referral sources, so community providers, patients themselves and their family members, with a well-marked pathway to care. Prior to Access CAMH's launch, accessing services at CAMH, you would have to know where you wanted to go for service. So you would have to have done the research yourself. There was unique fax numbers, processes, referral forms for all of our different services. So Access CAMH really looked to make that centralized and make it standardized. We currently would receive about 20,000 referrals a year that we process and disposition to services throughout our hospital. And we also operate a live line that would receive about 60,000 calls a year. Our model itself kind of has two different pathways for referrals. We have a paper referral, which is most commonly sent in via fax, and it's one standard form. So we took all those various forms that existed previously across the hospital and translated it into one single referral form. So providers can submit that, like I said, via fax. We also have it available electronically as well. And our team would process that and disposition the client to the most appropriate service. And then we also maintain a self-referral pathway. So these are for some of our services that are made available directly to patients. And so they can call our live line, they go through a standard screening process, and then they're dispositioned to the most appropriate service for care as well. So given these different pathways, our team is actually a pretty diverse team. So we have, our team is composed of clinicians who help provide oversight for our phone lines and the referral forms coming in to make sure that they're processed appropriately. And then, of course, we have administrative staff as well. What I will say, so we, as you know, we're about to launch the e-request system with Novari, and we're very excited about this. The comments that you made earlier about the different systems and processes from a technology perspective ring true for CAMH as well. So we've kind of just developed systems as we've gone with Access CAMH for the past, since we launched in 2014. So we're really looking forward to opportunities to streamline from a technology perspective. And one of the huge benefits that Novari brings is integration with our health record system. So we use Cerner as our EMR, and Novari will be able to integrate with that system. So that will really eliminate a lot of kind of duplicate processes that we have at Access CAMH. So we're looking forward to that, and then further opportunities that we think that this system will bring our team.
So Access CAMH is really a central single point of entry model to the organization. You said a minute ago, instead of knowing where the referrals need to go, you don't need to know that. You just, all referrals come here, and we, being Access CAMH, the team, we will assess them, triage them, and make sure that they get to the right clinic, right? So when you move to that model, leaving aside the technology, the nuts and bolts of it, I'm assuming there was significant change management, but what were the benefits of doing that, of moving to that model in the first place? Why do it?
Yeah, so there's a ton of benefits. I think one of the most important one is the benefit to the patient and their family, right? So our centralized system ensures that no one falls through the cracks, that we have a phone number that is, one phone number easily visible on our website or through other means that people can call and find out the status of their referral. So it's very client-centered, and that's been very important to us. I think also from a system perspective, it has also allowed us to take a step back and see where our kind of gaps in care, right? So previously, if someone, referred to a clinic and they got bounced back, no, sorry, you don't meet eligibility, end of story. Whereas when Access CAMH maintains that centrally, we can understand maybe where else would they be appropriate for, or is there an emerging gap in the services that we have available right now that we can escalate to our leadership and look to address.
We hear quite often, we hear it certainly when we talk to regions where there's multiple providers, so different organizations, where it's not all in-house, that one of the biggest single challenges, and it shouldn't be, but sadly it is simply moving to a standardized referral form. And you've talked about this now, I think twice you've mentioned, a standardized referral form. Now I see you nodding your head. So it's a big challenge. Everyone is happy to standardize to a common referral form. Everyone is in agreement with that on one condition, that you use their form. So we see that on a regional deployment of central intake models, and it's a big challenge to overcome. But was it a challenge internal to CAMH to try to standardize?
Oh, absolutely. It took a lot of work, and it continues to, right? So as Access CAMH operates, our critical stakeholders are all of the services that we disposition to within the hospital. And so we meet with those providers sometimes on a weekly basis to check in about how they're doing. Are they getting the right information that they need? If they're starting a new service offering, do they need different kinds of information? So we're constantly working with them to make sure that they're getting the information that they need, but balancing that with standard and efficient processes at Access CAMH. And one question we always need to come back to is, what is the basic amount of information that you need to get the right patient to care? Because there will be a lot more information that we can collect on folks once they arrived, but let's just work to make it efficient to get them to your door.
So, John, I'm just a question here. As I hear both Nala and Stephanie talk, and as we explain kind of that central intake approach and standardization of forms, I think about OHTs and the evolution of these health teams and how they start to need to do a similar approach, which is you're almost providing a service across what would be like an OHT model. And I think that's an important approach, is the standardization of some of that forms and automation, because the OHTs are going to need to do something like this as well. And this is a good working example of what that could look like. And it would serve as a good example to share back to OH and as these OHTs evolve as well.
So, Peter, you make a good point, but really, if we just step back, it doesn't really matter the structure. You're, of course, referencing the healthcare model, the structure of healthcare in the province of Ontario, where we've got Ontario Health OH and OHTs. Ontario Health Teams, a fairly new animal and still developing in the healthcare ecosystem. And you're right. There's a case to be made for central intake with regard to the OHTs. With hospitals, health authorities, it doesn't really matter. At the end of the day, what you're trying to do is improve access to care for patients. At the end of the day, you're putting a patient in front of a provider. It's how are you getting that patient to the right provider at the right time with the right data, I think. So I think you make a really good point. Stephanie, let's come back to the, you mentioned you're in the middle of implementing Novari eRequest. That's a sort of Swiss Army knife of software applications that facilitate central intake, single point of entry model, and workflow management. So what are the benefits of deploying and enabling technology? Why not just continue to use that hodgepodge of an Access database and email and fax and paper and Post-it notes?
Mm-hmm. I think efficiency for our team, like that stands out as one of the biggest ones. Right now, we need to, take a form and then do data entry from the form into our health record system. All of that takes time, energy, resources that could be spent otherwise processing referrals and, reaching out to clients, getting them service. So that's a critical one. And then, I think also this system will allow us to build greater logic into our processes, right? So if we know that the reason for referral is ABC, we can get that referral right over to the right queue right away for booking, and it needs kind of less resources handling it. So which again should lead to shorter times for processing referrals and getting people access to care.
Really the same reasons that Nala deployed it then back in the day. Sure, the reasons align. we've got clients across Canada that use Novari software. Most clients never really know that they're in Novari. Novari's in the background, and that's changing now. Our software now sends SMS messages and emails out to clients and patients. But until that time, they never knew that the software really existed, and that's fine. But only once has a patient ever reached out directly to Novari Health, and it was actually in Halton, Nala. It was a client's family who asked how did I believe it was their son, how did their son get access so quickly? And they were told the process, and the family actually reached out to Novari to thank Novari. So I think what you're doing in the space of healthcare and mental health, and then using an enabling technology, you're proving that this can be done, and you're accelerating care. And you probably get thanked all the time by patients and clients. I'll tell you, we don't. And it was a real proud moment for us when someone took the time to actually reach out to the software company that helped play a small role in making all this possible. So I'll leave it there, Peter, and I'll just pass it back to you.
Okay, great. Thank you. Some great questions, some great insight. And, as I hear things, kind of as you explain kind of what you're doing, it's interesting to kind of see the value and the benefits this could have for a lot of other things happening as we try and align and integrate across the healthcare system in Ontario, right? Not just referrals, but, the whole care coordination, care management as well. So that was great. Thank you for Stephanie and Nella and John. You know your solution very well, and I think you've been a great coach, and I think you've helped a lot of organizations solve a lot of those problems around central intake and care pathways and referrals. And it's great to have solutions like what Novari brings to the Canadian healthcare system. So thank you. So with that said, I just want to thank Stephanie and Nella and John for sharing your learnings and experiences at CAMH and Halton Healthcare. And again, Novari for what you do around central intake and really helping address those mental health challenges and access to mental health care. So what I'd like to do is really close things out and thank everybody for attending today. And if you want to learn more about the Microsoft Cloud for Healthcare, which is where Novari delivers a lot of their solution using Azure and a lot of our technologies, you can visit. There you'll find more healthcare technology webinars, Canadian healthcare provider case studies, and some great partner innovations like Novari and others to really help support our healthcare system in Canada. As a quick reminder, myself and the rest of the panelists will be available for Q&A via text. You can ask questions and we will respond and answer your questions. And again, so I wanted to thank everybody for attending, and we'll see you at the next episode of Microsoft Digital Series for Healthcare. So thank you, Nella, Stephanie, and John.
Thank you, Peter.
Thank you.